Outside, I would like to thank the organizers, Nanded OBGY Society, and all the seniors here for welcoming me for this lecture. Today, as she mentioned, I won't be talking only on hysteroscopy, but I have, with due permission from Dr. Dinesh sir, that I would like to incorporate laparoscopy as well, so that it will be a complete package of hystero laparoscopy surgeries, which you are going to see now. So today I'll be talking on fertility enhancing hystero laparoscopic surgeries. So direct vaginoscopic and hysteroscopic inspection with adequate distension and visualization discloses almost every vaginal and intrauterine abnormality with high accuracy. Additionally, it enables exact localization of the pathology and determination of its intercavitary extent. Laparoscopic reproductive surgeries intended to improve fertility may include surgeries on uterus, ovaries, pelvic peritoneum, and the fallopian tube. So without going into much detail of the basics, I would like to say that hysteroscopy, this pictures depicts what hysteroscopy is. Actually, we need to see life from a different perspective, exactly what hysteroscopy allows us to do in infertility. A simple vaginoscopy, which includes the inspection of the external os, then vagina, cervix, is shown in this video. We use no touch technique hysteroscopy, in which we do not put a speculum, we do not hold the cervix with valcellum, we just obliterate or just close the labial introitus, we close with hand, and we put a hysteroscope inside, let the distension medium do its work, and then you get a beautiful picture of cervix and vagina. Here, a simple vaginoscopy can give you a picture of infection. This is a chlamydial infection, which sometimes you miss it if you do a direct hysteroscopy, in which you put a valcellum, you dilate the cervix and put your hysteroscope inside the uterine cavity. So two major points are missed in this. First of all, you do not do vaginal inspection, cervical inspection, and cervical canal inspection. That should be done in each and every case. Here you can see a picture of detailed aspects of the plica palmitae and the appearance of two tree branches called arbor vitae. Here is the video of the same shown. Here we are doing put the hysteroscope in cervical canal, and we are just reading the cervical canal. So even in cervical canal you may get few polyps or something like that, though you shouldn't miss that, and you should see the anatomy is right or not. Now, simple inspection of uterine cavity. After you enter the uterine cavity, you need to read the endometrium, you need to see the anatomical perspective, in which you just do not go inside and see whether there is septum or not, there is polyp or not, or both ostia are seen. This is not the only case. You need to read the endometrium. Here you can see the endometrial glands are seen. All the white dots are endometrial gland. This is called as reindeer sign, which is typically seen in PCOS patients. Then even small things like micropolyps and patches of hemorrhages tell you that there is a presence of infection there, endometritis is there. You need to treat that first. Otherwise, just seeing the anatomy do not suffice the purpose. Here, appreciate the appearance of micropolyps, and even the presence of edema and hyperemia and micropolyps suggests that there is a endometritis. So these are micropolyps which are so tiny, and you can see a blood vessel growing into it. Now simple, this is another video of bubble test. What is bubble test? You, without putting a scope, you can just see whether the fallopian tubes are patent or not. You can just put the bubbles, and bubbles entering into the cornal end makes you understand that the fallopian tubes are patent. Here you can see bubble has disappeared into the cornal end. That means that fallopian tube is patent because the fluid is going into the abdominal cavity. Now here on this, in this video, we can see a small polyp is there. That polyp need to, this, if you don't take care of this, it might grow in future. Again, it will have some implications. So by just blunt dissection, I have just dislodged the polyp. It was small, that's why this can be done. This is a typical micro, or I say magnified picture of a polyp, in which you can see a detailed aspect of the vascular axis of an early polyp. Now this is another case of a large polyp which is occupying the lower portion of the uterus. Here it is a just beneath, beside, I would say, cranially to the internal os, you can see a large polyp occupying whole of the cavity. But as you advance your hysteroscope, you can just enter into the cavity and you can see both the osteas and upper segment of the uterus, upper portion of the uterus is vacant. So in this case, just to show, initially we used to do this because we used to cut the stalk. This should not be done nowadays due to advancement of the hysteroscopic instruments. Now with availability of bipolar resectoscope, there is very good and chance of removing these polyps by resectoscope. Here the polyp has been cut from the base. Sometimes it becomes very tedious to remove such a large polyps through cervix. So you need to do a gradual dilatation of the cervix, and if you're lucky enough, you can just grasp it with your hysteroscope forceps and pull it outside, or you can just put a ohm forceps and take it piecemeal out. This is possible when it is a polyp. When it is a fibroid polyp or it is a myoma proper, you can't do this. It is not a fragile thing which you can from at the base. You need to cut it from breast. I need to just show this video because my good friend of mine, Dr. Nitin Shah, has come up with a paper presentation wherein he has dealt with such polyps without using a current cautery, in which they cut the base of the polyp with scissors, and when the polyp is retained into the cavity, you need to pass a laparoscopic instrument besides your hysteroscope. Here you can see a grasper, his laparoscopic grasper, which is passed besides the hysteroscope, which is pulling that polyp outside the uterine cavity. Here a large submucous myoma is seen, in which you can see in which resectoscopy is used and the fibroid is been cut in pieces. Nowadays glycine is not used. With the advent of bipolar resectoscopes, we are using normal saline for this procedure with less complications. Here, piece by piece, the fibroid is been cut. Sometimes the fibroids which are like grade 2 submucosal myomas, in which you need to cut till the base, you need to deflate, you need to put the pressure down, you need to empty the cavity with, from normal saline, then that rest of the fibroid which is into the myometrium pops out. Again you need to do the distension with normal saline, and you can see that the fibroid which was intramural, it pops out so that you can easily cut it out. Here the portion is cut which is intramural, and this is the complete clearance. The cavity is free of fibroid now. Now moving on to next is T-shaped uterine cavity. This is a typical I would say a case which are seen in infertility practice, wherein such cavities we see on HSG and on ultrasound. Such cavities need to be dealt because these might be the cause of infertility in a vast number of cases, in which you can see the hysteroscopic picture. Here hysteroscopy is put. This is a 30-degree hysteroscope. You can see that deeply seated ostia is there. To see the ostia, you need to manipulate your hysteroscope in such a way that you need to visualize the ostia. Otherwise the lateral pelvic wall is so much convergent, you cannot see the osteas whenever you are keeping your hysteroscope at the level of internal os. You don't get that triangular panoramic view. So in such cases you need to do a lateral metroplasty. So even you can appreciate the tubular cavity. Here you can see that tubular cavity. You can't see the internal os from the level of the tubal ostia from the level of internal os. So in such cases, we initially used to do it with a bipolar hook. In this, we are using a bipolar hook, and we are taking gradual cuts on the lateral wall of the uterus. This is called as lateral metroplasty. There are two ways of doing it. With current and mechanical, that is with scissors. Here you can see it is done by bipolar hook. So typically in this, whenever you are using current or hook, surgical hook, you need to start it from the level of ostia and you need to come down till the level of isthmus. In this case, you need to remember that the depth of your cutting should be more towards the corneal end, and it should go on decreasing as you approach the internal os, because the thickness of the internal os near the internal os thickness of the myometrium is less. Now same procedure is being performed with scissors. Now you can see this, that we are doing it in a retrograde fashion. Now we are starting from the distal end of the uterus and we are approaching towards the ostia, and we are having a deeper and deeper cuts as we approach the ostia. So same procedure is performed on other side, and you can see that now the internal os is easily visualized from the ostia is easily visualized from the internal os. This is the relook hysteroscopy, in which you can see the same patient which has undergone lateral metroplasty. Now you appreciate the cavity and the correction of the anatomy which is done with lateral metroplasty. Here you can very nicely see both the ostias. The roomy cavity is there. There is no indent of lateral indentation or lateral convergent walls. Now moving on to another video. This is lateral metroplasty in unicornate uterus. We started doing lateral metroplasties in unicornate uterus just to increase the cavity space, so that at least few couple of weeks can be added to that pregnancy. So same procedure is being performed here. Now the one point I would like to mention is that initially we used to do it with cautery, but we eventually noticed that by doing it with a bipolar or monopolar cautery, the endometrial growth in subsequent scan is not good. So we shifted onto a mechanical cutting where current is not used, and still the same results are achieved, and we get a good endometrial quality or good endometrial thickness in subsequent months. Here the thick portion of the uterus should be cut in unicornate uterus, because you need to have that thickness as well, because there are chances of silent rupture in future pregnancy. Here is another case of the uterine septum in which a partial septum is seen. Partial septum, it is very much evident that from the internal os you can see a partial septum. It has been dealt with a mechanical scissor. The technique here is you just cut the septum till the level of the ostia, that straight line should be there. Over correction should not be done. Under correction is always better. Same thing applies here, because we are cutting endometrium here, myometrium here, in which in future pregnancy we have seen that silent rupture may happen during whenever the pregnancy is like 35 weeks, 38 weeks. Patient go into silent rupture if you perforate it or it is too much of thinning of the myometrium is there. Then moving on to another interesting case, it is endoscopic management of complete longitudinal vaginal septum in extending into the cervical canal up to the fundus. So this is the vaginoscopic view where we can see complete longitudinal vaginal septum is seen. You can see both the cervices, both the cavities which is been divided by the longitudinal septum. Here this can be easily dealt with your pencil cautery. You can just put the speculum, one on anterior wall, one on posterior wall. You can just with pencil you can cut the septum till the cervix, but just to show I have done it with a monopolar cautery, monopolar hook using glycine. Here the vaginal septum is being cut. You need to watch that you should be in center. You should not go too much anteriorly or too much posteriorly, so you should not injure the posterior or anterior wall. Cautery allows you to be very precise, and secondly the bloodless field is there, so it gives a good visual picture. Now this is done till you reach the cervices. Once you reach the cervix, you can just take the pencil cautery or same this monopolar cautery or bipolar hook, and you can cut the portion in between the two cervices. These patients typically need os tightening because it is too much patulous os, so you need to remember that such patient should be offered os tightening in future. Now once you cut the cervical portion, you can just proceed with hysteroscopic scissors, and you can cut the rest of the septum from internos to the fundus with scissors. Being a broad based thick septum, it is being very much difficult for scissors to tackle it, but just to avoid current, we have to take this pain as a surgeon. Now complete clearance has been done. We have reached till the fundus. Now total cavity, we can see both the osteas. Some remnant portion which is seen can be cut, and you get a good view of the cavity after you finish the procedure. There might be few additions after some time, so you can put a Buckley balloon or some number 8 Foley's catheter inside the cavity, and you can add up some estrogen to prevent the future adhesions which can happen. This is another case of femoral block in which coronal cannulation is being performed. I'll just give you a few tips because I'm considering that all of you must be doing Hystero Laparoscopic surgeries. Here one tip is that initially what we here coronal cannulation is done. The tip of coronal cannulation is that you need to cannulate the cornea only. You should not pass your guide wire through and through the tube because it damages the tube, the cilias are damaged, and future you may land up in ectopic pregnancy. So only the coronal portion of the tube should be passed through guide wire, and then you should push the dye. You can see it is successfully done and dye is been seen pouring out of the. Some unexpected findings, these are some micro polyps which are seen whenever the cavity is distended, then and then only you can see a few polyps which are coming out of that cornal end. These polyps are sufficient enough to block the fallopian tube whenever the cavity is collapsed. So such micro polyps, tiny polyps can be removed. Sometimes you get an interesting finding where retained products of conceptions are seen. Here you can see a patient had a previous DNA and some portion was stuck to the corneal portion, right side cornea. It was removed hysteroscopically. Then this is osseous metaplasia of endometrium, where you can bone fragments are formed into the endometrial, and you need to remove those fragments because it is one of the cause of infertility. Now moving on to laparoscopy. This is a case of genital cox. As I mentioned earlier, you need to evaluate uterus, fallopian tubes, ovaries, as well as the peritoneum, because these are the surgeries which help you to correct the cause of infertility. Here a simple inspection is seen, and you can see Fig-Hugh-Curtis syndrome where perihepatic adhesions are seen. This is a typical case of chlamydial infection as well as genital cox, in which both things can happen. Now this is another case of gross hydrosalpinx. Many of the times these scenarios are not picked up on ultrasounds, so you need to put a scope sometimes. I had a patient with a chronic abdominal pain. She was frequently visiting. We had done 4 or 5 scans from radiologists, but nobody was able to pick up the gross hydrosalpinx. Just because husband was annoyed, and he said that let's put a port and see why she is complaining so much. I am visiting hospital so many times. Then we came to know that it was a gross hydrosalpinx which was causing the pain, and the patient was not lying. Sometimes we get a normal ultrasound and we find that everything is normal inside. That should not be scenario. You should always listen to patient. In such cases, obviously hydrosalpingectomy is done, and you should go ahead with IVF. Now this is a parafemoral cyst. Why to remove parafemoral cyst? Because sometimes due to that pressure, that fallopian tube drops into the POD and they could not lift up the egg from the ovary. Now this is a case of neofemoroplasty. Whenever the tubal length is not adequate, you can think of neofemoroplasty, but the principle of this is that minimum 5 cm and above length should be there of the proximal end, so that it should be able to reach up to the ovary and pick up the egg. Because if the results are not that good, if the length of the fallopian tube after neophimbrioplasty is say less than 4 to 5 centimeter. But now with advanced IVF, I don't think such surgeries are now done and advocated. Here cruciate incision is made and 4 flaps are made, and then 4 flaps are reverted and sutured. Now moving on to the simple ovarian cyst. Here you can see a ovarian cyst which is extending into the broad it is fallen onto the broad ligament. This is another large cyst. Cystectomy is being performed here. You can see the torsion, detorsion is done. You need to be very vigilant during such cases, because I think we are doing maximum cases under spinal anesthesia. I don't know what is the scenario here, but in such cases you need to be very particular and have everything ready, because such patients might go into shock, because after detorsion many prostaglandins and many factors are released which may cause sudden cardiac arrest of a patient. Here an interesting case is shown. Now this is a ovarian fibroid, fibroma. So it is a large fibroid which has grown into the ovary. It is a very hard to remove. It do not have good planes, and it is very much stuck to the ovarian tissue. It is difficult to enucleate it and remove, but as we are having a lecture on fertility enhancing surgeries, as far as possible at least you need to preserve the ovary. So you can see after enucleation, this is the fibroid is being pulled out, you get a good chunk of ovary which is remained behind. You can just morcellate this fibroid out, or you can just remove it from POD, whatever way you are comfortable with. Now you can see the remnant remaining ovary, that is good enough. Now moving on to another case of endometriosis. I would like to skip this slide. Another case of interesting large endometriosis, where it is a 20 centimeter large endometrioma which was almost 22 weeks size, which was a mobile solo endometrioma, and it was very much difficult to remove the collection inside, because due to the chronic this was a chronic case, that thick fluid became it has become like a firm consistency. It was difficult to aspirate it, so we took a lot of time to perform this surgery. Then moving on to fibroids. Obviously, as shown, fibroids, there are different kind of fibroids: intramural, submucosal fibroids. This is a serous fibroid which is anterior wall. We do it with vasopressin. We inject 20 units of vasopressin diluted into 200 ml normal saline. You need to inject it at the cervicofibroid junction, and you need to take an incision. If the fibroid is anterior, you can go with a horizontal incision, and if the vertical incision, and if the fibroid is posterior, you can opt for horizontal incision. It eases your laparoscopic suturing. Fibroid is being enucleated. If you use vasopressin, you get a good bloodless field. Here you can see that good bloodless field is there. At the base, you can cauterize the vasculature which is supplying the fibroid. Once the fibroid is totally removed, you can suture the uterus with barb sutures. The fibroid is being completely delineated. Now you can suture it with barb sutures. Here baseball suturing is done. The technique typically is inside out, outside in. You can suture it in 2 layers if the defect is big enough. You can opt for a single layer suturing as well. That totally depends on that scenario. Same way adenomyomectomy can be performed. Many of the times radiologists and even the gynecologists get confused with fibroids and adenomyoma. Here same injection vasopressin is injected, then a bold cut is made on the it is bit hard to cut adenomyotic tissue, because over uterus you get the myometrium which is easily cut and then you can enucleate the fibroid, but scenario here is different because all of that is myometrium which is hardened, and that adenomyotic tissue removal is bit difficult. You can see that maximum portion of the adenomyoma is been removed and the uterus is been sutured. Typically uterus is sutured in the same fashion whatever we have done with fibroid. I won't go into that detail. This is the end view. This is typical hysteroscopic picture of adenomyosis, where you can see small openings are there. Sometimes if you just cut these openings you get a fluid coming out of it, brownish colored fluid comes out of it. That is typical indication of adenomyosis on hysteroscopy. Now I would just like to show you an interesting case of severe hemoperitoneum caused by ovarian bleeding. It is a rare complication of transovarian oocyte retrieval. Now post oocyte retrieval, patient came on to third day. Patient came on to third or fourth day with in hemorrhagic shock. She was straight away taken for laparoscopy, in which I can't just forward this video, but you need to bear with this. प्ले नहीं होता है. Just a moment. Longer time between the interval of TVOR and surgical intervention may land up into removal of the ovary. Here you can see a gross hemorrhage after oocyte retrieval. Problem with these ovaries are these ovaries are too much fragile. To attain hemostasis, it is bit difficult. You can see all the puncture sites. It is bleeding from all the puncture sites, and it is bit difficult to achieve the hemostasis. So the simple technique which should be followed is, you need to coagulate in such a manner that the blood which is coming out of the ovary should be coagulated, and it should form a crust over that raw area, which helps you seal the, you can appreciate the gross hemorrhage which was post oocyte retrieval. Now see, it is very difficult to coagulate it, because there is not a single point which is bleeding. Everything, the large defect is oozing. So you need to form a crust over that defect. You need to have patience, because by doing this you will save the ovary. Otherwise you may land up doing oophorectomy. Now you can appreciate that it was taken care. Now there was no bleeding. Then you can just put a ab gel or something to prevent further bleeding. And the ovaries are so much fragile that even by holding it, it might get teared off. And this is the way it was done, and thin crust of that coagulated tissue was formed over that, and the hemostasis was achieved. Then the abgel is being put, and you can appreciate the end result, in which we were able to preserve both the ovaries. Later she delivered as well. See, now another case of interesting case of isolated fallopian tube torsion with the normal ipsilateral ovary. It has no classical clinical feature, but there are no reliable radiological investigations those prompt that. You can appreciate here that both the ovaries are seen very much normal, and there was an isolated fallopian tube torsion. So you need to detort it first, and obviously a salpingectomy was done. There was no way to save such kind of fallopian tubes. Detortion is being performed here. So many torsions. And the tube was removed. Another case of para-ovarian cyst, it accounts for at least 10 to 33% of adnexal masses, and most commonly due to detortion of the anatomy, they might cause infertility. Here a large para-ovarian cyst is noticed. You can see, appreciate the ovary is separate. It mimics that it is originating from ovary. Once you dissect it out, you will get that picture. You can see the stretched out fallopian tube over para-ovarian cyst. It has elongated so much. These cysts are most easy to remove. Only you need to cut the mesosalpinx and just dissect it out. It is like cakewalk for a laparoscopic surgeon. You can appreciate that it is very easily coming out. And this portion I wanted to show you that it is not arising from ovary. You can appreciate here once I dissect it more. Now see this, it is totally separate from ovary. And by just blunt dissection you can achieve that. There was another one here. Just aspirate the fluid and you can just take the cyst wall out of the 5 mm port, lateral 5 mm port. You can just widen the port site and you can just pull it out, which I'll just show you here. You need not put an endo bag in this case. Now it is being removed. Last slide. I'll just one case I'll show. This is accessory cavitary uterine mass. It is a cavity lined by a functional endometrium. It is not a rampant cause of infertility, but it has shown in few infertile patients that this might be the cause. On hysteroscopy, you are not able to pick up this mass which was seen on laparoscopically. You can just confirm it by putting a aspiration needle, and the menstrual blood which is being collected into that cavity is spilled out. Just take a incision, enucleate the cavity, enucleate that cavitatory mass, and you can suture the uterus afterwards. So among reproductive operations, most of them could and should be done by hysteroscopy and or laparoscopy. Endoscopic surgery for infertility patients, when performed by experienced endoscopist, is efficacious and can produce good or better results than traditional procedures. Thank you. Thank you very much. Have a happy Sunday.